Okay, I think we're ready to begin.
Want me to start?
Yes, please go ahead, Monica.
One more minute.
No, we are ready to begin.
Okay, good afternoon, everybody, and welcome to our hearing intervention, cognition, and brain health results from the Aging and Cognitive Health Evaluation in Elders randomized trial. Our guest presenter today is Dr. Frank Lin, an ear, nose, and throat doctor, as well as epidemiologist at Johns Hopkins University, who leads a lot of studies examining the impact of hearing loss on cognitive decline, dementia, and brain aging in older adults. His work has served as the basis of the 2017 Lancet Commission report on dementia, concluding that hearing loss was the single largest, most easily modifiable risk factor for dementia. At this time, I'd like to introduce Dr. Lin. Dr. Lin, the floor is yours.
Thanks so much, Monica. And I appreciate all of you guys joining on a virtual call. I know sometimes virtual calls can be tough. As Monica mentioned, by way of background, I'm an ENT and I'm an epidemiologist where a lot of my research over the last 15 years is focused specifically on the intersection between where hearing intersects with brain health. And what I'm going to do in the next about 40-45 minutes is sort of share with you the results of something called the ACHIEVE trial, which I'll sort of describe in depth with the design as well as the results over the next 45 minutes or so. I encourage any of you guys to ask questions. Feel free to just put in the chat. I know Hannah's going to be monitored for me. And then if it's something that's pertinent for the thing, then she'll interrupt me. Otherwise, we'll save questions till the very end. The first thing I have to mention, of course, as with any ACHIEVE trial, any randomized trial, it takes a large group of people. So when I'm sort of presenting here today, I say I very am much presenting on behalf of a much larger group. The ACHIEVE trial is represented a collaboration over the last 10 years involving 8 different academic centers across the United States. The main field sites have been at Mississippi, Hopkins, Wake Forest, and the University of Minnesota. But then Cliff Jack's group at the Mayo was sort of MRI Reading Center. The University of South Florida designed the hearing intervention. The University of Pittsburgh designed the control intervention you hear more about. And finally, UNC has been the data coordinating center for this trial that still actually continues to date with the long-term follow-up. Now, the main thing I'm going to share today or results that actually previously resulted out a couple of years ago now in the Lancet. It was actually the cover article basically where it said that, based on the evidence from the ACHIEVE study, that hearing intervention may be a particularly important global public health target for dementia prevention efforts. And what I'm hoping to do over the next 40-45 minutes is sort of tell you where this quote came from for the basis of it per se, as well as the evidence behind it, as well as what remains to be done in the field. So the brief outline, what I'll cover in the next 45 minutes or so, really touch really briefly on some background where hearing intersects with dementia in terms of existing sort of epidemiologic evidence. Then talk to you sort of in depth about how the ACHIEVE study was designed, sort of a unique design. All trials are fundamentally simple, but this one's a little bit of a unique design I'll go over. Describe to you the ACHIEVE cohort characteristics. Then talk about some early evidence for evidence that the hearing intervention even works for actually just improving sort of target engagement, namely communicative function, how that trickled down potentially to effects on global cognitive decline. Then share with you actually some unpublished results looking at the MRI structural data that we have now as well. And finally, just a very brief summary at the end. So in terms of background, like what we studied and why, Monica alluded to this before, as all of you know probably, the Lancet Commission on Dementia in 2017, again in 2020, and again 2024, has been charged with looking at all the extant literature, looking at potentially modifiable risk factors for dementia, and sort of combine them into one essentially large meta-analysis to essentially look at what are the major potentially modifiable risk factors. In 2017, 2020, and actually again in 2024, hearing actually in mid and late life is consistently ranked as arguably the single largest potentially modifiable risk factor in terms of population attributable fraction of risk. So assuming complete causality and assuming that you can completely reverse hearing loss, which is obviously a theoretical exercise, but really seeing it rise to a very high level. And I think it's for 2 reasons. One is because hearing and hearing loss is incredibly common. The inner ear is post-mitotic. It can't regenerate. So everybody, no matter who you are, no matter what you do, everybody's hearing monotonically declines to some degree as we get older. So if you look at a clinically significant level of hearing loss, roughly about 2/3 of everyone over 65 actually has a clinical level of hearing loss. So if you have a very, very common risk factor, And the risk ratios between hearing and dementia have been quite large relatively in other epidemiologic studies for going back 15 years now. You multiply those two together, and that's why you have such a high population attributable fraction of risk being attributed to hearing loss as a risk factor for dementia. Now, one thing that's really important to note, though, is we say potentially modifiable. And we say potentially modifiable because there are some established hypothesized mechanistic pathways that causally potentially link hearing loss, per se, with risk of things like cognitive decline and dementia. And the first idea, the first mechanism per se, is the idea of cognitive load, also called the information degradation hypothesis. And what this effectively essentially posits is that when you, as all of us have some degradation or hearing over time, what it fundamentally means that the inner ear is sending a much more degraded signal to the brain. So instead of sending a very clear signal to the brain, it sends a much more degraded signal. And at that point then, with auditory processing, cognitive processing required for processing auditory signal, does that constantly garbled auditory signal tax the available cognitive resources that, if they weren't being used on hearing, could have otherwise been used to buffer against known pathological contributors to dementia, such as Alzheimer's disease or microvascular disease. So this mechanism is not so much that hearing loss, I should say, causes dementia, but it can lead to much earlier exposure of dementia symptomatology, dementia phenotype, because you essentially have less of the cognitive reserve or cognitive resources available for buffering against other dementia pathologies. And the thing to keep in mind about hearing is a task that your brain is always doing, whether you like it or not, right? So even in a quiet room, imagine sleeping at night, your brain is still processing sound around you constantly, because that's why you hear a weird sound and you wake up at night, for instance. So this is likely, what's been shown is likely some degree of a fixed cognitive load in the system by virtue of how our brain processes auditory information. So that's one mechanism. A second mechanism, which sounds similar, but it's actually, I think, very, very distinct, is the idea that hearing loss in and of itself can have direct negative or adverse effects on brain structural integrity. Namely, the thought here is that if you have an impoverished auditory signal ascending from the brain, that parts of the lateral temporal lobe that receive that signal gradually become essentially less stimulated over time. If you see this actually both in animal studies as well as longitudinal human studies, where you see, if you look, let's say, human studies, serial MRI scans, you see that greater hearing loss is associated with risk over time, not cross-sectional risk over time, with greater rates of brain atrophy with the lateral temporal lobe. I should say too, you also see some ultra-functional connectivity. It's not only structural, but you're also seeing reflected in functional connectivity as well. So this mechanism sounds similar, but it's actually very different. It's the idea that hearing loss, quote unquote, in and of itself, can potentially adversely affect the brain structural integrity, not just leading to load in the system, but actually can adversely affect structural integrity. The third mechanism is probably the most intuitive for any of us who actually work with adults or older adults who have any degree of hearing loss. It's the idea that hearing loss in some way, shape, or form can contribute to social isolation, loneliness, and loss of social engagement, right? And as we know now why this is linked with cognitive decline dementia, likely has to do with remaining engaged in cognitive stimulating activities, maybe in physical activity, stress, inflammation possibly as well, but many different potential pathways through which we think now how social isolation and loneliness can precipitate risk of cognitive decline dementia. Now, the important thing to note about these three mechanisms, there's evidence actually for all three, and likely it's not that one is right, other ones are wrong. It's likely a combination of all three. That could likely be variable to some degree between individual, but likely all three are in play. Now, the reason why I took some time to explain these mechanisms, though, is because if we believe that these are in play, we believe there's evidence for all three, which actually is, it actually theoretically suggests then that our existing interventions that could be used to, quote unquote, treat hearing loss, let's say for a hearing aid, for instance, and learning how to use it well, that they could directly modify these mechanisms and theoretically modify and reduce risk of cognitive decline dementia over time, right? So the idea of using a well-fit hearing aid that's properly programmed and adjusted and you're shown how to use it is you certainly hope by providing a clear auditory signal to the brain, you can reduce that cognitive load, right? And that's why a lot of times people will say they're struggling and they're getting really tired after being out all night in a busy restaurant. So the idea of you provide a clear auditory signal, make it easier for the brain per se. The second mechanism, obviously, if you're providing increased auditory stimulation to the brain, that can potentially retard against any adverse effects on brain structural integrity. And finally, the whole reason you even think about treating hearing for many people is that hopefully allows you to remain more socially engaged. So from a proof of concept perspective, it really brings up this idea then that hearing intervention in mid and late life could theoretically, from a conceptual point of view, potentially reduce cognitive decline dementia by directly modifying these pathways. Now, as you can imagine, though, this is a theoretical idea. Conceptually, it makes sense. But this fundamental question of whether you actually treat hearing loss and actually reduce cognitive decline or dementia really remain unknown. And the reason for that is you can't answer this question with observational studies, observational data, as much as you like to try. Because you can imagine if you look out in the community, you look at people who have hearing loss, people who use hearing aids are very different than people who don't use hearing aids, right? Because hearing aids are so expensive. You're essentially healthier, wealthier, and better educated and more health conscious if you use hearing aids. So if you see any observational data showing hearing aids associated with reduced risk, is it, quote unquote, because they got their hearing treated, or is underlying factors that allowed them to get a hearing aid? It's very, very hard to disentangle. Now, people have tried, though, and actually there's a really large meta-analysis done, published in JAMA Neurology just about 2 years ago now, where they looked at all the extant observational studies that have looked at hearing aid use and cognitive decline, even after doing various propensity score analyses, et cetera, et cetera. They still found that hearing aids was associated with a 19% reduced hazard of long-term cognitive decline. But again, it clearly goes in the right direction, but no one really believed it yet. And you can imagine the only way to really answer this question is you have to have a randomized trial, right? And amazingly, until the ACHIEVE trial was done, there had never, ever been done in the history of science a randomized control trial that ever looked at the long-term effects of hearing intervention on things like cognitive decline or even more functional outcomes, things like socialization and loneliness. So the whole basis of the ACHIEVE trial was basically to do this. It was designed to answer one primary question, namely, if we address hearing loss in older adults, can we in fact reduce the rate of cognitive decline over 3 years, right? And essentially in a group of older adults who otherwise have essentially no cognitive impairment at baseline. I'll go over the inclusion criteria in a second. So it's called the ACHIEVE study. The main focus primary outcome was global cognitive decline, which I'll define a little later. And then a whole bunch of exploratory areas we looked at as well, looking at brain structure, mental health and well-being, physical functioning, accelerometry data, healthcare use. These papers have all been resulted out now as well, but so I'll give you a high-level highlight of what these results are at the very, very end. Some are actually still in press. But the main focus of today's talk will be on the global cognitive decline. I'll share a little more about the brain structural data, but the other outcomes I'm going to just give a very survey at the very, very end for those of you who are interested. So the study design for ACHIEVE, like any randomized trial, is conceptually simple. So from 2018 to 2019, recruited nearly 1,000 older adults around the United States, 4 different centers I'll go over in a second. Everyone was between, when they entered the study, 70 to 84 years old. They had untreated mild to moderate levels of hearing loss, and I'll go over what that means in a second. And they all essentially had, quote unquote, normal cognition or no substantial cognitive impairment at base. I'll go over what that means in a second as well. Now, what's interesting is that of the 977, we recruited from 2 distinct study cohorts. About a quarter of the study came from basically the ERIC study, or the Atherosclerosis Risk and Community Studies. This is an ongoing longitudinal study of older adults. We've gone for 30 years. And we nested our trial within their field sites. So we recruited some of the same people who are already in the study, who, when they were recruited many years ago, were literally just a random sample of the communities that was designed to look at essentially midlife health factors and later life cardiovascular events. So truly as close as you get to a random sample. So we couldn't get everybody from the study. There weren't enough older adults in the study who are the right age. So we recruited 1/4 from this existing cohort study of older adults. And the other 3/4 we call the de novo group. These are people who recruited essentially de novo. They were recruited through advertisements, Facebook ads, newspaper advertisements saying we're doing a healthy aging study. Please join if you'd like to receive one of 2 different interventions. So again, 1/4 came from an existing observational study, 3/4 basically newly recruited. You can imagine those 2 groups may be a little different, and I'll go over how different they were a little later. Of those 1,000 people then, they were randomized, flip of a coin, obviously, to hearing intervention, to go over what that means in a second, versus an aging education control intervention. I'll go over what that means in a second as well. They're then followed every 6 months for the next 3 years. And the final 3-year outcomes are those listed on the right: global cognitive decline, which I'll show you what I mean by that later, being the primary outcome, and all the other exploratory outcomes below. Now, I mentioned this before, but the ACHIEVE study, as you can imagine, starting any new randomized trial takes time and expense. So we're able to leverage the existing ERIC study. The ERIC study, funded by NHLBIs, went for 30 years, 4 different study sites you see on the map there on the right, existing field sites in the communities, not clinical centers, are all existing field sites, following 15,000 plus people for the last 30 years. Right? It's pretty amazing, actually. And when these people were initially recruited 30 years ago, they came from a random sample. They were recruited from motor vehicle registration polls, voter registration polls, things like that. So they were randomly sampled back then, and then they've all aged over time. So we recruited from, we used existing field sites, used existing study personnel, used existing protocols, so it made it a lot easier. And because of that, we also recruited from ERIC, but we couldn't get everybody from ERIC. And that's why in the end, if you look at the cohort for Achieve, about 1/4 of the sample came from the ERIC cohort. Again, these are participants who were randomly recruited, sampled from many years ago, versus the de novo cohort, newly enrolled 70, 84-year-olds who respond to advertisements and Facebook ads and things like that. Everybody, when they joined this study, they were randomized to one intervention or other, and they're told that 3 years later, they would also get the other intervention. So if you got the healthy aging education intervention first, 3 years later, you get the hearing intervention and vice versa. Now, the main inclusion criteria there on the right, that's not all of them, these are the main ones. 70-84 at baseline, based on an education stratified MMSE. We're basically trying to sort of exclude anyone with substantial cognitive impairment at baseline. These people all had untreated hearing loss, basically something called a pure tone out between 30 and 70 decibels. That's basically a mild to moderate hearing loss. Put that in perspective, that essentially about half the people in that age range would have this level of hearing loss. So this is not the minority. This is almost fully half of people in the age range would have the level of hearing loss required for this study. Something called word recognition and quiet, that basically just gets at whether or not they can still benefit from a traditional hearing aid as opposed to need something fancier like a cochlear implant. And everybody was community dwelling. Now, the interventions themselves, so everyone was randomized, either hearing intervention. So hearing intervention, best practices, you met with a study audiologist at the field sites. I was trained to do this. About 4 sessions over the first 3 or 4 months where you got your hearing aids, you're shown how to use them, any other assistive technology needed. And then every 6 months thereafter, they had a semi-annual booster visit where they saw the audiologist and just hearing aids are tweaked and things like that. The other arm of the study, AC got a real program. It's called the 10 Keys to Successful Aging. This is actually a real CDC-funded program for how you train older adults in healthy aging topics like nutrition, exercise, diet, vaccination. So people were randomized to this arm. They met one-on-one with a health educator, often a nurse, who was trained how to do this program. And about 4 sessions over the first 3 months, they got each of these different keys to healthy aging, about 1 hour each. Then every 6 months after, they had a booster session. So the 2 groups were completely parallel in terms of exposure to study personnel. And as you can imagine, that's important because just by seeing audiologists, maybe that's good for you, but you're getting stimulated. But both groups had the same amount of exposure to study personnel over the 3 years of the course of the study. The brief design, exceptionally simple, baseline assessment, baseline visits, baseline randomization, of course, every 6 months visits thereafter. The primary endpoint, which I'll describe what that is in a second, it's changed from baseline to the year 3 global cognitive standardized factor score, which is derived from a comprehensive neurocognitive battery. I'm going to find all this in the subsequent slides. Secondary cognitive outcomes looked at domain-specific cognition as well as an adjudicated measure of cognitive impairment. And then we also had a whole host of other pre-specified exploratory outcomes, which I'll go over a few of them down below, and then I'll give you the summary results at the very, very end. So this is the neurocognitive battery. The Achieve neurocognitive battery was based off the ERIC neurocognitive battery, which was conceptualized many years ago by David Notman's group, as well as Tom Mosley, Malin Albert, and Cliff Jack. So this is a well-established neurocognitive battery. Probably many of you recognize many of these tests that are very, very familiar to many of us. And these 10 tests have been used in the ERIC study since the late 2000s. So that's what we followed, the same existing neurocognitive battery, since all the protocols were in place for training the psychometrist, the scoring, the adjudication, things like that. The one thing I always like to point out, though, that's really interesting is that 8 of these 10 cognitive tests are not completely dependent on auditory stimuli. So the only 2 that have some are auditory only stimuli are digit span backward and logical memory test. Everything else actually is auditory and visual stimuli. And that's important because we want to make sure our results aren't being confounded by just someone being able to hear better. They can hear the word better and hence they do better. Short of those 2 cognitive tests, and that wouldn't be the issue. More importantly, Before we do any neurocognitive testing, the psychometrist always trained to do, we actually had this test of speech understanding to make sure people are understanding words correctly when they're read to them, to make sure this was not being confounded by not being able to hear the stimuli. And again, for any of us who do neurocognitive testing or who knows hearing loss, if you're face-to-face with someone with even a moderate level of hearing loss in a quiet room face-to-face, its speech understanding is not compromised. It's if you get into very extreme, severe, profound hearing loss, it could be in quiet. But in a quiet room face-to-face, it really shouldn't be. But we actually verify this ahead of time before we did any neurocognitive testing. And on top of that, 8 of the 10 tests were completely not dependent on auditory stimuli only. Now, what's been done many years ago by the Eric group and Alden Gross and others is to analyze the 10 neurocognitive tests rather than doing some type of just combined Z-score. We actually did a factor score. This was established well a priori over a decade ago before we began the study. But all 10 tests are used to compute a global factor score. So rather than a Z-score, it allows for individual item weighting and things like that. So you can extract one factor score. The factor scores are standardized to the achieved baseline. So if your score is 0 at baseline, it means you're right smack dab in the mean. If your score is 0.5, that means you're half a standard deviation above the mean. Likewise, negative 0.5, you're half a standard deviation below the mean. Likewise, change over time is interpreted the same way. So as all of us know, if you decline by half a standard deviation, that's considered likely clinically significant. So same way it's interpreted, these are all in SD units change over time, right? And a factor score is a little more powerful there than a simple Z-score for doing this well. All right, so this is a really busy slide. I'm going to go very briefly, but we can talk about it more for those who are interested. In terms of statistical analysis, obviously there's a randomized controlled trial. So what you're estimating at the end is the effect of assignment to intervention versus control on change in global cognition from baseline to year 3. It's a primary outcome. These are mixed effects models. We control for a host of pre-specified covariates at baseline to improve precision. We adjust for baseline levels of hearing, recruitment source, field site, age, sex, etc. These are all pre-specified ahead of time to increase precision and estimate. Frankly, about missing data, which is fortunately very few, I'll show you. We actually pre-specified, we did multiple imputation by chained equations, a sort of a relatively bias-free way of imputing missing data. Fortunately, again, that was very little. And you get the same results whether you do complete case or multiple mutation. The main analysis always focuses on baseline to year 3 cognitive change. We only use the year 1 and year 2 results if someone died before year 3. Now, very importantly, pre-specified years in advance was that the primary analysis for this trial was obviously using everyone, but we also said we would replicate the primary analyses stratified by the recruitment source because we recognize that people who came from a random sample of the population, namely ERIC, could behave very differently in terms of response to hearing intervention and things like that than people who recruited de novo from Facebook ads, right? So a very healthy population versus a random sample population may behave differently. So pre-specified well ahead of time, even designed the study from the very get-go, is that we would replicate the primary analyses in the whole cohort, but then within each different recruitment cohort separately as well, understand that they may behave differently. And you'll see how different they are in fact in a second. One thing I'm always really proud of for any of us who have run clinical trials is, the death knell of any clinical trial is recruitment and randomization. We projected for sample size 850, recruiting over 18-month period. We began January 2018. The blue line is what we would have done if we hit right on target 18 months. The black line is what we did. So we were literally 2 weeks behind schedule, recruiting 850 participants. At that time, given that recruitment was going really well, the NIA authorized to go a little bit longer. So we actually kept recruitment just going for another couple months, and we got to a final sample size of 977. This is the consort figure. It's a little big, it's a little busy. The thing I want to emphasize in the end is that the thing we're really proud of, it's really a testament to the study staff, is that we have complete year 3 follow-up data through a pandemic on 90% of people. So 10% of people were lost to follow-up. Some passed away, many passed away, some people moved away, but complete follow-up data on 90% of people. We had projected 70% in our initial sample size calculation. So we hit 90, and I think this is a testament again to the study staff as well as the commitment that the participants felt to the study because they're getting something from the study as well. So very, very complete data. We did do imputation though for the missing data just in case though, and the results are basically the same either way, whether you do complete case or imputed data. This just shows normally you would see this baseline characteristics divided by intervention versus control. I'm not going to show you that because it's basically the same because it was a well-balanced trial. What I'm showing you here, though, which is really interesting, is the baseline characteristics by the recruitment source. So I suggested before, Eric being a random sample population may be very different than a newly recruited 70 to 84-year-old cohort. That's exactly what you're seeing. You're seeing on average the de novo cohort. If you look at education, they're more highly educated. If you look at their income levels, they're essentially wealthier, which is not surprising for a healthy cohort recruited in their 70 to 84 as opposed to a random sample recruited many, many years ago. The Black race is different. If you look at that, that's a bit of an artifact. And the reason for that is the Eric cohort, when it was originally recruited 30 plus years ago, 1/4 participants were fully recruited to be essentially African-American Black. So it was enriched for African-American participants. So that's why Eric, it's still relatively enriched. De novo follows much more the population demographics for those established field sites. Actually, that's why you're seeing this disparities there specifically. But you're also seeing that the de novo cohort compared to the Eric cohort, they're healthier. If you look at rates of diabetes, 17% versus 28%. Living alone, they're less likely to be living alone, right, as well. If you look at their baseline cognitive factor scores, right, if you look at across the line, here's this global cognition. Obviously, in all participants at baseline, it's 0 by definition, it's a mean. But if you look at the error cohort, they start below the mean. The de novo cohort, being very healthy volunteers, start above the mean, right? So again, not surprising in terms of probably many of us observed when we do dementia studies. People who come to these studies are often the healthiest of the healthiest, as we're sort of seeing here, where a random sample is very, very different than people who volunteer to join a study from a Facebook ad when they're 70, 84 years old. You're sort of seeing that directly reflected in the cohort characteristics at baseline. All right. So the first thing I'm going to show you before jumping to the cognitive results is something that's really important is there even evidence of target engagement? A lot of people say, well, I don't want to wear hearing aids. I don't like my hearing aids. Is there any evidence people are even using their hearing aids and it's benefiting them? Because if it's not, any effect on cognition is likely not going to happen. So one crude way of looking at this is just looking at hours of hearing aid use. You can look at the self-report, or actually you can query the hearing aid when they come in. You actually interrogate how many hours that device was used. They actually match it pretty well. So this is looking at the participants who were randomized to hearing intervention. You see at 6 months, all the way through 3 years later, the median rates of use. These are histograms. You got to turn your head and your side a little bit. And you see there's variance, obviously. Some people use it a lot, like 20 hours per day. Other people use it fewer. But it's consistently through 3 years of a study, through a pandemic, we're still seeing median rates of use, which are still really, really good overall. And there's some variances. Some people they only wear it when they go out at nighttime or during the day, and at home they may not wear it. So that's why you're seeing variance. But consistently as a whole, consistent rates of use, which is reassuring. Now, importantly, does that mean it actually helped them? So there's something called the Hearing Handicap Inventory. It's a self-report scale that looks like that asks, do you struggle in conversations? Do you feel embarrassed when you go out? Things like that. So higher scores are consistent with more, or basically considered higher hearing handicap per se. So if you look at this, if you look at the gray bars, the left is the control intervention. The right is the hearing intervention. So at baseline in gray, they start about the same level. They start around a score around 14, which is considered a mild, essentially, communication impairment. If you look at the health education control over 3 years, their scores actually get a little worse over time. Their hearing is not being addressed in the study. Versus you look at the hearing intervention, it drops within 6 months and it stays down over 3 years. So showing that at least on initial target engagement, the hearing intervention is clearly benefiting some people in terms of their overall communication experience. All right. Now, does this actually trickle out then to effects on 3-year global cognitive change? So this is a primary outcome of the study. There's a busy figure, so I'll take you through it slowly. The top right there is what you're seeing. That's a global cognition. If you look in the first column, control group, negative 0.202. So they basically, over 3 years, the control group declined by negative 0.20 standard deviation units over 3 years. So 0.2 SD unit change in cognition over time. If you look at the intervention group, they declined by negative 0.200. So effectively the same. You look at the forest plot there on the right there, a little over, right there in the middle, it's essentially no effective hearing intervention over 3-year cognitive change. If you look at the 3 secondary cognitive domains, executive function, language and memory, maybe a signal and memory, but just nothing clearly to write home on, clearly nothing meeting pre-specified criteria. So on first pass, this was a null trial finding, right? Seeing no difference between 3-year rates of global cognitive decline. Now, what gets interesting, though, is I mentioned that in the original design of the study, we had always specify a priori that we're going to replicate the primary analyses within each different recruitment source, understand they may behave differently. This is exactly what you're seeing. We didn't realize how differently, though. So if you look at this, if you look at the ERIC cohort, if you look at global cognitive decline in the top row there, control group declined by negative 0.402 SD units over 3 years. Intervention in ERIC declined by negative 0.211. So basically roughly about a 0.19 SD unit difference, which corresponds to about a 48% reduction in the 3-year rate of global cognitive change among the ERIC cohort, who really represented a random sample of the study population at those 4 different study sites. You see, if you look at the 3 different specific cognitive domains, executive function, language memory, seeing the same thing. Strongest effects actually arguably in the language domain. This is language production, not language reception, of which is a completely non-auditory task, by the way. This is like category fluency and letter fluency, for instance. In contrast, you look down below at the de novo, the healthy volunteer cohort, you're seeing no effect of hearing intervention at all within 3 years. So why the difference? If you look at the numbers a little closely, it probably becomes a little clearer potentially why. If you look at the baseline background rate of 3-year global cognitive change in the control participants in the ERIC versus the de novo, right? So ERIC controls decline by about 0.402, almost half SD unit over 3 years, something clinically meaningful, probably most consider, versus de novos decline by only 0.151. So you're seeing nearly a 3-fold faster rate of global cognitive change in the ERIC controls versus the de novo controls. And, you know, in 2020 hindsight, this sort of makes sense. You saw the baseline demographics being different between the 3, the de novo cohort being essentially, honestly, healthier, wealthier, better educated. So having a very, very slow rate of cognitive change versus the ERIC cohort having a slightly faster rate of cognitive change. So quick summary of sort of the main trial results is what this was resulted on the Lancet a couple of years ago at this point now. The total combined cohort, hearing intervention had no effect on reducing cognitive decline within 3 years. If we look at the stratified results, which are specified a priori, we arguably see strong effects in ERIC, basically a 48% reduction corresponding to about a 0.2 SD difference between the 2 groups. And it suggests that the hearing intervention may indeed reduce cognitive decline, basically in populations at risk, right? Which sort of sounds intuitive. The whole premise of the hearing intervention is to reduce cognitive decline. You have to have a population at risk of cognitive decline to detect a treatment effect. Apropos to that, in a de novo, really seeing no effect over 3 years. But again, one thought here is maybe the main thought for why we're seeing this is a very slow rate of cognitive change in very healthy de novo volunteers. It basically, you won't be able to, it limits the ability to observe any treatment effect of a hearing intervention within just 3 years at least, right? And again, the slow cognitive decline de novos, I think, as probably many of us realize, if you're getting healthy volunteers responding when they're 70, 84 years old to like Facebook ads, for instance, they're likely very different than a population that was originally sampled randomly from the population many years before. All right, so those are actually the main trial results that came out a couple of years ago. What I'm going to transition to now a little bit is sharing with you now some of the other sort of exploratory outcomes that we gathered in the CHIEF study. And the first one I'll show you in particular is the brain health, the brain MRI data. So specifically, the reason why we looked at this is that if you go back to the very beginning of the talk, where we talked about different mechanisms that potentially link hearing and cognitive decline dementia. One of the main mechanisms is the idea that hearing may have sort of adverse effects on brain structural integrity. So then that raises the idea that naturally, does that mean a hearing intervention within just 3 years, right, potentially have effects on maybe slowing any rates of brain atrophy? Now, the brief background for this, for why that mechanism is even invoked, is that for those of you who remember back to your neuroscience days, so, you know, obviously the brain relies on arguably 6 main sensory afferents, of which hearing and vision are probably the dominant ones. But the peripheral auditory afferents are integrated across multiple different brain regions and neural networks. So default mode networks, salience network, et cetera. And that makes sense. It's given one of our main afferents that our brain relies on. What's been shown in the past already, this is based off epidemiologic observational data, is that hearing loss or impoverished auditory encoding, same thing, is associated with functional changes in terms of both resting state and task-activated neuroactivity, right? So you see that it affects functional changes in the brain. And actually see it also being associated both in animal studies and human studies with increased structural atrophy over time, over whole brain, particularly the lateral temporal lobe, cingulate cortices, as well as other areas as well. There's been only one ever study that ever looked per se at hearing aid use and how it may affect the brain. It was a relatively short-term study, looked at basically functional measures of I think it was an fMRI study or high density EEG, I can't remember. Actually, it was high density EEG, showing that within 6 months of hearing aid use, that you saw some reversal of cross-modal plasticity in the brain. So a lot of times, what you see is you'll see visual cross-modal takeover of auditory areas with hearing loss, but seeing within 6 months some reversal of that, at least on this one high density EEG study. But there never nothing had ever been done looking at the broader long-term effects of hearing aid use or hearing intervention on brain function and structural integrity over a longer period of time. So within the ACHIEVE study, we had an MRI sub-study. We had a half sample of people who got baseline 3 Tesla MRIs. This was a protocol overseen by Cliff Jack's group at Mayo, which also oversees the ERIC MRI protocols. And 3 years later, we got MRI scans on 300 of them. We would have liked to have been higher, but in between that period from baseline to year 3, we had something called the pandemic. And as we're coming out of the pandemic, bringing people back in person, all the MRI scanners at all field sites were completely backlogged from mainly clinical patients. So we couldn't get all 445 back in. We couldn't have probably gotten a high anyway, but we did as best because we got 303 of the 445. We're still in the window where we get their 3-year MRI scans, despite MRI scanners being backed up at the time as we came out of the pandemic. This is basically 2022 at this point almost. These are all 3D Tesla 3D scans on 3 Tesla Siemens scanners, or calibrated across all the study sites. ROIs were defined using FreeSurfer, and again, and cortical thickness was measured for each region. Again, this was all done by Cliff Jack's group, though. You see the consort figure there. Roughly, I won't go over too much. I'll give you the summary results that are presented similarly to what you saw before. Now, I'll preface and I'll say briefly, when we got the MRI data, I probably shouldn't say this, we weren't expecting to see anything. I mean, 3 years is not much time. So take this with a grain of salt. We weren't going to see anything. These are all adjusted analyses or linear mixed models adjust for the same type of baseline covariates. Anything you're seeing leaning to the right, it favors intervention in terms of reduced rates of cortical thickness atrophy over 3 years with a hearing intervention versus control. So this is across a frontal lobe, temporal, occipital, parietal, and whole brain. We focus here less on the p-values and just the confidence interval. So I think what you can say here is that there clearly appears to be a signal going in a direction where broadly we're seeing the hearing intervention being associated with reduced rates of cortical atrophy, cortical thinning, within a 3-year period. I mean, arguably some of these actually p-values do cross 0.05 if you depending how you do the adjustments. This is the most conservative model here, but seeing a very, very clear, I would say, direction of effect toward a positive effect. We see this across in both ERIC participants and de novo. It's not unique to ERIC de novo. Effects are stronger than ERIC because ERIC actually has fast rates of brain atrophy, but you're seeing commonality across the direction across both groups. This is probably a better way of showing it. This is just a map of it, obviously. The darker blue basically means there is favors the intervention with reduced cortical thinning over 3 years versus control. Red basically means theoretically there's more thinning with intervention versus control. You're seeing it's really centered in sort of multiple brain regions, but a few areas that really jump out is one is the pars orbitalis, part of the area which is critical for integrating sensory and auditory inputs, actually, which sort of makes sense there, as well as a cingulate cortices is there. You see the bottom right again, sort of a way station for how a lot of auditory and other stimuli are processed. So seeing the strongest signals there, but sort of diffusely through many different areas, but in a couple of areas which sort of, again, sort of post hoc hand waving sort of makes sense for understanding how auditory information is processed in the brain. So quick summary here from the MRI data. This is all actually sort of unpublished right now. It's still in review right now, and we're doing some other harmonization MRI analyses that the editors have requested. But I would say the analyses, they seem to demonstrate a clear signal of hearing intervention being associated with reduced cortical thinning over 3 years, and basically the whole brain as well as certain lobar regions. Interesting, the pattern of findings suggests that hearing intervention made the greatest effects in the pars orbitalis and cingulate cortices as we described before. And it's actually not even the temporal lobe, actually. It's other areas which have actually not directly been associated with hearing loss in a way, but you're seeing that effect. And, again, with post hoc 2020 hindsight, it sort of makes sense because even though hearing loss has been associated with lateral temporal lobe atrophy, we can't forget that when we do this intervention, we're actually not reversing the hearing loss. We're not restoring hearing. We're providing a cleaner input. So you're not seeing effects actually in the temporal lobe, maybe because we're probably not reversing the hearing loss, but we're providing clear signals to other parts of the brain, signal coming in that maybe affects other areas. That's sort of, again, post hoc hand waving there, but one explanation for maybe why we're seeing where effects localize. Potential mechanisms, this is a complete hand waving, I apologize. But theoretically, maybe effects of hearing intervention on sustained alterations in neuroactivity. I think that's probably clearly one pathway supported by other research, as well as more diffusely, maybe increased social and physical activity and engagement, right? Which could have sort of untold effects, but clearly makes sort of a common sense sort of idea too as well. All right, so quick summary of the main trial results and some of the MRI findings here, just one sort of overview slide. I hope many of you agree that over 3 years, we saw very high adherence to and satisfaction with hearing intervention. So by rates of use, hours of use, the hearing handicap scores, right? So that's encouraging. That's clear target engagement. The MRI analysis I just showed you, it appears to suggest a biomarker effect of the hearing intervention on reducing cortical thinning, actually just within 3 years, actually. We saw relatively strong effects of the hearing intervention on 3-year global cognitive change in the ERIC cohort that came from random sample of the population. We did not see an effect in de novo again, obviously, but they had a very slow rate of cognitive change that could be limiting what we can see in 3 years. Key inference, I think, expressed on the cover of the Lancet, and I think how other people are interpreting it, is the idea that hearing intervention could indeed reduce global cognitive change, global cognitive loss within 3 years for population of older adults that are actually going to experience cognitive change in 3 years, right? Now, if you're a completely healthy 50-year-old, for instance, I don't think a hearing intervention is going to reduce any cognitive decline, but you're not going to experience any. Likewise, the same for a 70, 84-year-old who's very, very healthy, responds to a Facebook ad. There may be no intervention effect within 3 years, but there's nothing to really reduce per se. What's next for Achieve? I'll highlight this is that all these other exploratory outcomes I mentioned before and sort of in the top right, these have actually all been finished, analyzed. Many are already in press or already published. I'll go over the very high level overview there for a second. And more importantly, we're continuing long-term follow-up, right? So 3 years just may not be enough to see change, especially in the healthy volunteers. So we have underway with funding from the National Aging. There is a 6-year follow-up study as well that's still underway. We'll final 6-year results by roughly end of next year. Yeah, end of next year as well. So that'll be the sort of 6-year follow-up of the study as well. This is one quick summary slide I'll give you. Hearing intervention versus control over 3 years. Top right, as we just discussed, is the global cognitive decline, specifically the ERIC cohort. Along the top half the arrow is all the other exploratory outcomes where we saw a positive effect of hearing intervention, right? So we saw an improved communicative function. By the way, the asterisks basically mean whether it's published, in press, under review, or it's still in preparation. So the top arrow, we saw improved communicative function. We see reduced fatigue based on self-reported scales with hearing intervention. We actually see reduced falls. We actually queried falls every 6 months. So we have a total fall count over 3 years. We're seeing a reduced number of falls over 3 years as well. Metrics of social isolation, objective social networks, or loneliness. We see positive effects of hearing intervention there as well. The brain atrophy I told you about before, that's what you just showed. We're actually interestingly also seeing it, I didn't show you these results yet, in white matter hyperintensities. I'll be honest, we're being very cautious how we interpret that because as many of us know, we typically interpret white matter hyperintensities with microvascular disease. So I think no one actually really knows the direct biological mechanisms. But we're seeing a similar pattern where hearing intervention is associated with reduced white matter hyperintensity growth over a 3-year period in roughly similar regions. So it parallels the obstructional MRI data as well as, I'm not showing the DTI data, but it parallels the same actually. Again, but we're being cautious how we're interpreting it. That was now an a priori hypothesis we just did on a lark because we had the analysis, the data was already there, and we looked at it. On the bottom half of the arrow is where we see over 3 years no effect of hearing intervention having a beneficial effect, just really just no effect at all. Those are on physical function, actually objective physical functioning. You actually see a signal on balance, but is a global SPB measure, so we saw nothing on the total effect. Physical activity, same thing on terms of like activity, you play tennis and things like that. Didn't see an effect there. I think it's actually not surprising. I think it's very hard to change physical activity in an older adult at that point, within just 3 years at least. Likewise, depression, no effect on depression. Give the caveat there, the cohort at baseline had very low CESD scores to begin with, so there wasn't much depression to really change. Finally, health-related quality of life, actually no effect there, but this is a global measure of health-related quality of life. If you look at social function domain-specific and quality of life, you actually do see a positive effect there, but because of how we framed the analysis is looking at the global SF36, you don't necessarily see an effect there. Actually, the effect, I should say, it goes in the correct direction, but it's just a confidence interval that's still relatively wide. So we're cautious how we interpret that data. I will finish up here and just mention before I said I was presenting on behalf of the team. This is a list of all the original investigators and staff that began the Achieve study. Many of who are still involved many years later across these 8 different study sites. A photo down there below, we had the kickoff study in 2017, feels like ages ago now at this point. I will mention that the funding has all come from the NIA, very fortunately, with generous funding to NIA through multiple different NIA grants over time, as well as ERIC contract as well that's funded the ERIC cohort studies for many, many years as well. I'll finish up there. I'll say there is a dedicated study website called the Achieve Study website that many of you, if you want the most recent results, you're welcome to look at it. I will say too that end of last year we just deposited all the year 3 Achieve data into a public repository. So that goes into it's actually under the NHLBL bio link because we put in the same data repository so it existing with the ERIC data, so they're sort of seamless to access. But that's available. Actually, might not be available yet. We deposited, but given everything with NIH, I'm not sure when they're actually going to make it available. But it is. We did everything on our side to make it available at least. Thank you very, very much. And I'm happy to take any questions or comments or thoughts. Thanks.
Wonderful talk. Wow. Really great work on this study, and people are recognizing that through some questions that they have for you. So I'll take these mostly in the order that they've come in. If you want to continue submitting questions, please use the Q&A box. But Addison Berg comes in with the first question of, what went into selecting this cognitive battery test as your cognitive outcome, and what considerations need to be made in measuring cognition in hearing impaired populations?
Oh, great question. So I mentioned before, so the neurocognitive battery used for Achieve came directly from the existing atherosclerosis risk in communities neurocognitive study. So that's been around since that neurocognitive battery, I think, was developed in the late 2009, 2010 period by, again, the NCS neurocognitive team is basically Dave Notman, Marilyn Albert, Cliff Jack, and others, Tom Mosley. So they developed that neurocognitive battery years ago within ERIC, and then rather than reinvent the wheel, we took the same neurocognitive battery and bring it across to Achieve, mainly because all the field sites were already accustomed to how to score it, how to administer, and things like that. So you'll see that it doesn't follow necessarily a traditional cognitive battery, yet a lot of the tests are the same, but we followed an existing cognitive battery to not have to reinvent the wheel. The second question you bring up is, how do we adapt neurocognitive testing for hearing impaired populations? The first thing to note is that for many of us who work with older adults above 70, hearing impairment is by definition the de facto norm almost. Like everyone in that age range essentially has some degree of hearing impairment, mild going to severe, but somewhere in that direction. So this is people you've been working with all the time already. The most important thing I think a lot of times is that standard neuropsychometric testing techniques, face-to-face, quiet room, minimal distractions, in those settings, short of honestly a severe, profound hearing loss, verbal communication is not compromised. You can ask someone to repeat shadow back words, and you repeat 5 words, they'll be able to repeat it back, right? Because that's how you can verify it. Within the context of the Achieve trial, we really want to make sure, and the Achieve trial was only mild to moderate hearing loss, so we're sort of already relieved that wouldn't be an issue, but just to verify, and this actually, we have a paper published on this, you can probably look it up. It's we had them follow a protocol where we took 5 sentences, each sentence had 5 keywords. We had the neuropsychometrists read these sentences one at a time and have the person repeat back the sentences and scored how many words they got correctly. So I guess it's some technically short-term working memory, but these are really short sentences. Just to make sure that we verified that their speech understanding was not being compromised. So that was going above and beyond for us in our case to do that. But typically I would say for most older adults, the moderate level, which is the vast majority of older adults, face-to-face, quiet room, arm's length, speech understanding is not necessarily compromised. Now, if you go to other extremes, like severe, profound, which will have some, there are tests that have different test forms that have no acoustic stimuli, for instance, like for example, the MoCA, many of us probably use at some point. The MoCA, it does have a version which has no auditory stimuli and has norms for it specifically. So the people are doing that. Some people do use things like pocket talkers and things like that, like a portable amplifier, which is, it's interesting. I mean, it gets a more of a philosophical argument for when you do neurocognitive testing in a clinic room. If you really want to be transferable to real life, they should be using in that clinic room the same assistive aids to be using at home. So I think it gets a little dicey if you think about using amplifiers in clinic, because it's not necessarily transferable then at that point. I think the more important thing, if you could do it many times, a lot of times it wouldn't be an issue already, or you switch to non-auditory test forms, for which I mentioned the MoCA specifically, and other ones have versions of.
Great. Another question that came up across a couple of attendees is wondering if you've considered the hours of using hearing aids in your primary analysis. Someone noticed that about 15% of people in the hearing aid group reported wearing their hearing aids for 0 hours per day in year 3. And if you would see a decreased rate of cognitive decline in the ERIC group when removing or accounting for those.
Great question. So those are all getting into like the I would say the sub-studies of the main data, looking at what modifies or moderates the results. We've started looking at a little bit actually. The reason why it gets a little tricky, though, I'll tell you, it's not necessarily monotonic between how many hours you use a hearing and how many you benefit, right? It depends on the mechanism. So one of the mechanisms you think is really social engagement. Some people will say to you, like, I only need it when I go to restaurants. And if I'm at home most of the day on my own, I don't bother. They sort of are irritating. I don't need to, right? So factoring that in as a hours, it's hard to sometimes because it means different things for different people. If social engagement was the main modifying sort of mediating variables. In contrast, if you think, for example, let's say brain MRI structure, maybe hours use does matter. Maybe it makes it more important, but there's so much variance there that, and as you know, with any type of epidemiologic study, if there's a lot of variance interperson in terms of the response to intervention or what a factor means, your results are biased toward the null. So the first pass of everything is that the hours used doesn't seem to make that much of a difference depending on what outcome it is, but there's a lot more nuance there we haven't even dug under the hood yet. We just honestly haven't had time to get around those analyses. The last year and a half, we've been so focused on other primary outcomes, other exploratory outcomes, that we're just now turning to some of these other sub-studies that we need to begin. But great point. It's long story short, we're thinking about it. We just haven't gotten around to doing it yet.
Sounds great. Another attendee asks, the Lancet report puts hearing loss as a midlife modifiable risk factor. The Achieve study had older participants. What results would you predict for a sample of 45 to 65-year-olds?
So this is such a good question. So like this comes up all the time with how the Lancet figure works. And then it's funny, I was in London last week meeting with Sergio Cosfreda-Gonzalez and Joe Livingston, who lead the Lancet Commission. So we didn't talk about them, but it's come up before. In the Lancet Commission figure, it's hearing loss is put in midlife, purely sort of as convenience, because, well, I shouldn't say it bounces to figure out more. It does bounce to figure out a little more. But hearing loss, it's not that it comes on only in late life. It's hearing loss comes in midlife and just progresses incrementally over time. So I think in a lot of the Lancet studies, the ones they included in their meta-analyses, anything up to 65 is considered midlife, actually. So if the observational data they're looking at has participants who are less than 65, they just classify that risk factor in midlife theoretically. But you could have just put that factor in late life too. It's just the figure is just conveniently putting in midlife, but it's almost semi-arbitrary. But yeah, hearing loss is something that everyone experiences, and it likely for all of us, actually, I hate to tell this, everyone's hearing begins to decline in your 20s, actually. It's monotonic over your time. So where you classify is just a matter of convenience. But essentially, we're looking primarily at older adults in any of these studies, mainly because those are the populations that would be experiencing cognitive change.
Great. Another question is if there is any relationship between brain volume and cognitive outcomes on the participant level, and if you analyzed any hippocampal volume changes in the MRI data.
Pausing. So Yeah, we did actually, because if you look at the ROI analyses, it's showing that one summary figure. I didn't show the whole table. All the ROIs are all pre-specified in advance. So there was nothing specific for hippocampus in terms of the hearing intervention effect that we saw. The main areas, again, were the cingulates and other areas I showed you. Actually, we didn't see anything specific in the hippocampus. I'm trying to think of what the direction of effect was, but I can't remember the top of my head. But nothing really. And I'll put the same, but put a pin that too. In terms of observation data in the past, we've actually never seen hearing loss being observation associated with actually the sort of the more medial temporal lobe areas. It's primarily the lateral temporal lobe, sort of the non-AD specific areas in many ways. Yeah.
Great. Another question is, are you still planning to use a crossover design?
Oh, yeah, great question. Yes, we have to. I mean, ethically and responsible and informed consent wise, everyone in the intervention after 3 years, they also got the other intervention. So where that comes up a bit, actually, for the maybe the reason are asking is that when we go to 6-year follow-up of this trial, and that'll be end of next year finishing up, the results are not so clean anymore. It's not intervention versus control, right? Because the control group also got the intervention for 3 years and vice versa, right? Theoretically, right? In terms of if there's any benefit of the education. So the 6-year results are really being analyzed in the context of essentially early hearing intervention versus late hearing intervention. Are you seeing lag effects, right? Basically. But we from a scientific perspective, we would love to have kept them randomized and things like that, but we obviously couldn't. The same thing, I'll mention another thing too, which is really interesting too, is that for people who got randomized to the control intervention, you realize we couldn't say you can't get hearing aids, obviously not. So you actually see a fair amount of drop-in over this 3-year period. So people who got randomized control, they said, I'm not waiting for 3 years to get my hearing, and I'm going to get them anyway. I'll still be in your study, but I'm going to get on my own anyway. So there was actually about an 18% rate of drop-in among the control group. But the way we analyze the data is still completely intention to treat, as you can imagine, right? And as you can imagine, the drop-in was higher in the de novos who are healthier, wealthier, and better educated. Everything is still analyzed intention to treat. So the pin to put in that one potentially is obviously like any intention to treat trial. The results are arguably a little conservative. And you see that if we do the per protocol analyses or compliance average causal effect and things like that, the results actually get stronger. We don't present that. That's in the appendices for the Lancet article, but the results do get stronger because of likely that relatively conservative bias with intention to treat.
Wonderful. And then probably have time for 1 or 2 more questions. I'm going to revisit another one here. It says, amazing recruitment and retention numbers. They're really especially impressive in the year 3 retention. Can you say more about the characteristics of the 10% that dropped out? And was there anything different about the population? Did they have lower baseline cognitive scores, or what made sticking with the study more of a challenge?
Yeah, great question. So yeah, it's the 90% rate of follow-up in terms of click-through data is, I think, just really a testament to the study staff, as well as I think because the trial was ultimately giving participants something. Even the control group, a lot of people love the control intervention. They met one-on-one with the nurse educator. So the participants really, I think, benefited from both arms. I think it's the one key thing as well. On top of that, phenomenal study staff. The 10% rate of loss of follow-up, you can imagine the people were typically older. So I can't remember of the 10%, how many of those actually passed away within 3 years. I mean, these are 70, 84-year-olds through a pandemic. So a fair amount of them actually just passed away during the study, as you can imagine. Some moved away, like they moved to near their kids and we couldn't get back in and things like that. I can't honestly remember the top of my head the characteristics. I think it is in our appendices for the Lancet. Nothing really jumped out as being very surprising, I should say, though, in terms of things that would be a smoking gun. I think a lot of it was just related to mortality, actually, which is a study of older adults through a pandemic. And many people say they're surprised it wasn't higher, actually, but yeah, but nothing jumped out at us at that point. I don't remember the exact table anymore off the top of my head, though, but nothing jumped out at us.
Great. Well, we are just about at time. Thank you so much for this wonderful presentation and sharing all of this data and results with us. We're really excited to hear further follow-ups as the follow-up study concludes in the next year, as you mentioned. We just want to note that this recording will be published on the NAC YouTube channel, but I did want to double check with you, Dr. Lin, if you'd be willing to share your slides out after the talk as well.
Yeah, absolutely. I'll send those on PDF right now, make it a little easier.
Great. Yeah, so thank you so much to everyone who attended. If you want to share this webinar with any of your colleagues, feel free to find that YouTube link sometime next week. And yeah, just keep spreading the word about the incredible results of this study. So thank you, Dr. Lin, and thank you also to the ORCOR Steering Committee and Dr. Monica Parker for being so instrumental in organizing.
Thanks, everyone.
Wonderful day.